let's hear from some folks about what, as Dr. Yeshua called it, the ultimate judge and jury have told us, and when we ask in advance what matters to patients. So we will have a presentation from two researchers who've been deeply engaged in qualitative and quantitative research to understand what matters most to Alzheimer's patients. Then we'll have a discussion with some experts, patients, caregivers, and other experts in Alzheimer's disease. One minor point is you're going to hear me refer to these folks all by their first name. That is at their request. So without further ado, two leaders of the Alzheimer's disease patient and caregiver initiative, engagement initiative on the What Matters Most study, Carla DeMuro with RTI Health Solutions, who has spearheaded this as one of our contractors, and Ann Hartree, Associate Vice President for Value, Evidence, and Outcome at Eli Lilly, and not here because she works for Lilly, but because Ann did some of the very earliest research at a qualitative and quantitative level on what matters most to patients. So Carla and Ann, take it away.
Thank you so much, Russ. We are very pleased to be here and have a chance to talk about what matters most and the work that we've all done to bring what matters most to patients into measurement in Alzheimer's disease. As a little bit of background about myself, I'm a cognitive neuroscientist by training, but I've spent about the last 15 years trying to establish value of our treatments, whether it be in Alzheimer's or in other disease states. And value isn't just financial, but value to society and to patients and to caregivers and to clinicians, as well as, so that we can make our treatments even better. And as you pointed out, yes, I am both an employee and a stockholder at Lilly, although the majority of the work we're going to be talking about today is work I did while I was at a previous employer. But I'm happy to bring it to all of us today. A number of years ago, we were working on a symptomatic treatment for Alzheimer's disease, and we were in the position of having to describe to non-clinical trial experts what it would mean to have a 4-point change on the ADAS-Cog. So the ADAS-Cog is a measure we saw Dr. Irizarry refer to in the lecanemab study. It's a very well-known assessment, very powerful in a lot of ways, but it's very hard to describe what's meaningful about that official minimally important difference of 4 points. And so we were trying to describe this meaningfulness, and somebody on our team had the brilliant idea of let's ask patients. So we started talking to patients about what these changes might mean, and it very quickly became apparent to us that at least the language we were using was different than the language they were using. And when we dug a little deeper, we weren't even getting at the concepts that were most meaningful to them. And so we decided to take a step back and really start to understand what is meaningful to patients with Alzheimer's disease, and then to use that to assess how well our assessments were even working along those lines. So we started with a literature review. We went into the literature, found everything we could about what matters to patients with Alzheimer's disease, brought that all together into a bit of a compendium of about 45 things, and then went out and talked to patients. Now, we were focusing on patients with mild Alzheimer's disease, mild to moderate Alzheimer's disease at this point. But we were still able to have really good conversations with them and their caregivers about how these things mattered, which of these things mattered and how they mattered. And we were able to build a conceptual model, much like the one you see here, which organizes these things that matter into buckets that we can then assess. And then we took this list and we lined it up against the assessments we were using. And it will surprise very few people on this call to discover that they didn't line up very well. We had a battery of about 4 assessments, the best assessments that were available at the time, and they touched on many of these concepts, but they didn't really directly measure them. And there were a lot of these concepts, a lot of these items that weren't even measured at all. And yet this is what's meaningful to our patients. So it became apparent to us that we could really benefit, we and our patients could really benefit from a different way of measuring, or an improved way of measuring, or at least really understanding how well what we're measuring matters. And for a couple of reasons. One, when we measure what matters, the meaning of change on those measures is much more inherent to the description of the change, because we're measuring something that's meaningful. And so when it changes, it's a lot easier to explain and understand and value. Alternatively, if we're better at measuring these nuanced changes that are important to patients, we can get more sensitive measurement. We can understand changes in, for instance, earlier disease, and we can improve our treatments in the right direction. So we can improve treatments in the ways that are going to matter most. So about the same time, Us Against Alzheimer's was coming to a very much the similar conclusion. And they brought together in a pre-competitive consortium a group of companies, all with an interest in Alzheimer's disease, to come together to move this path forward. The first step we undertook as this consortium was to broaden out our scan of our patients, to go to the full range of severity in Alzheimer's disease, to start as early as even preclinical disease and go all the way through severe disease, and to understand what matters most across the full spectrum. So through refinements of our original list and through additional interviews and surveys with patients, we were able to winnow this down to 42 concepts, but we were gaining a huge amount of information around what matters to patients most across the disease continuum and to their caregivers. And with that, I'll turn it over to Carla to continue our story.
Thank you, Anne. Thanks so much. So just give a little background on myself. So I am not a neuroscientist, but I am a specialist in patient-centered outcomes assessment. So my role as part of the ADPACE Us Against Alzheimer's Consortia was to try to bring in some of that field of science to continue along the work that Anne, colleagues and the team have been conducting. So as Anne mentioned, we partnered with the group to conduct this very rigorous and broad qualitative study to gather really what we felt mattered most at the end of the day based on these qualitative interviews. However, we really needed to pressure test that in a larger sample and in a more diverse patient population. So we approached this thinking about a mixed methods research. So the next step for us was conducting a quantitative study. So in order to do that, we developed a survey that included all of the 42 items that had bubbled up from our qualitative research, and we attached an importance rating scale to those 42 items. That survey was then administered to nearly 300 individuals across the full spectrum of Alzheimer's disease. So from preclinical individuals living with Alzheimer's through care partners of individuals with severe Alzheimer's disease. So for us, what was really significant about this research was, first, those 42 items really helped. They held together across this very heterogeneous patient population. Having something hold together across the full spectrum of AD, as all of you who have been conducting research know how challenging that is to measure different components of this patient population. So these 42 items really held together and were rated as highly or extremely important in the individuals living with Alzheimer's groups, most highly, with more than 50% of respondents indicating that all 42 items were highly or extremely important. And then additionally, these results held up when we talked to care partners and gathered their survey results as well. They rated some things lower, indicating that there are potentially some differences in priorities when we think about individuals living with disease as compared to their care partners. But it was interesting how the 42 were still all of importance to these groups, but also reminds us that it's important to not only capture the individual living with disease, that patient perspective, but also make sure that we are incorporating the care partner perspective as well, especially as we move along the course of disease. Our next step was to try to think about how we could further evaluate what both individuals living with disease and their care partners told us were the most meaningful potential treatment outcomes to them. How could we further evaluate what this would mean in trial settings, both observational settings and clinical trial settings? The 42 items indicated that meaningful treatment goals included things beyond cognition, so functioning, leisure, behaviors, social interactions. So all of these factors were broad and encompassed more than just cognition itself. So in order to investigate how well we do this, being we, the research community and clinical trial community, how well we measure these aspects in the clinical trial setting, we conducted a targeted review of the literature to identify that the clinical outcome assessment tools that are most frequently used in Alzheimer's disease research today. And we then mapped our results of our 42 concepts against those measures. And as Anne sort of alluded to, and so you won't find it terribly surprising, they didn't match up all that well. We took a really close and careful look at 20 of the most frequently used clinical outcome assessments. Of those 20, only 5 included 12 or more items that were considered what mattered most by individuals and care partners. Now, we wouldn't expect a single measure to include all 42 concepts, but it seems like we could do a better job in making sure that there's coverage across these concepts. And our next step in what we're calling the next generation of what matters most studies will help lead us to better understanding and providing this level of support as we're planning trials and moving ahead. So being able to look across what matters most, what are the domains and concepts of interest to individuals living with disease and their care partners, and how can we align those with clinical outcomes assessment tools that would be best fit for the specific trials and patient populations that researchers are examining that would align with these very meaningful treatment outcomes. So the model that we've been sharing with you as we're talking is our first output from what we're labeling the next generation of what matters most studies. Here we really sought to conceptualize those 42 items, which sort of felt a little bit like spaghetti on the wall, when we have 42 things that go across many different domains. We wanted to be able to narrow those down into buckets, as Anne points out, so we can think across how to measure these. So a conceptual model is a really useful tool for doing that. So it allows us to look at things as in more detailed on an item level or more on a domain level. And then when we're planning studies in the future, we can think about which of these components of what matters most would make sense to measure in particular clinical trial settings. Additionally, that the What Matters Most Next Generation series of studies are going to seek to further evaluate and contextualize what does matter most. We're conducting additional qualitative research in a more diverse and inclusive patient population to make sure that these results hold true as we expand and include diversity in the subjects that we're including in the research. We are going to then use those findings to refine our What Matters Most list if any changes need to be applied. And then also focus our research with a bit more of a regulatory lens so we can support clinical outcome assessment moving forward in clinical trials and help to try to support generation of some of those endpoints and outcomes that will be meaningful at the patient level. So that qualitative research now is already underway. And then those results will be applied and a survey generated again, and additional quantitative research will be collected at that time. That will also allow us to gather additional details on what matters most items. So we're going to begin measuring other aspects that go beyond just importance ratings. So we'll measure aspects of the concepts themselves, and also really understand through a ranking exercise what matters most about what matters most. So being able to prioritize those across patients and caregivers. So just one other point I'd like to make, and I was thinking about it through the other talks, is it's really interesting and sort of validating to us as we look across the recent results that and lecanemab that were presented today about the outcomes that demonstrated and showed some of the largest treatment benefits. When we look at what mattered most to patients, the ADCS-ADL scale was one of those tools that had some of the best coverage. So it's very interesting to see that that's where the some of the largest treatment benefits were realized as well.
And I'll just add briefly, as Carla says, the work that the path we're taking this work on now is in that sort of regulatory measurement direction. But this work equally underlays any potential improvement or addition of a clinical trial measure, or more importantly, a clinical measure, something used by physicians to have the right conversation with their patients about their disease. So this foundation can apply in a number of areas. We're just going to the place that we think it can have the biggest first impact, but it has a number of applications.
Yeah. And I know I went through the data very quickly. There's a lot of data. As Anne said, we have generated quite a mass of it. So a little bit of a spoiler alert, there are 2 papers that'll be published next week in Neurology and Therapy that will give you all of the details to our quantitative assessment, as well as our mapping exercise, what we call the COA tech assessment. So those 2 papers will be available open access next week.
So thank you too. I wanted to follow up on a couple of things before we bring in all of our panelists, a couple of questions. So Carla, I know you just said that the papers are going to be out in a couple of weeks. Without spoiling too much, you mentioned also that no one assessment tool currently in common use measures anywhere close to 42 concepts. So we talked earlier with Dr. Cummings and Dr. Irizarry about the sort of concordance of a multitude of measures with Leqembi. It feels like that's especially important, given that we don't have one sort of measure outcome that captures everything. Is that a fair guess?
Yeah, absolutely. And I think that the model is a step in helping us to look across the different domains and think about which measures we could pull together. It would be a lot to have a single measure, try to measure such potentially disparate domains and items, but pulling together a core set of best fit measures that reflect these meaningful outcomes could be incredibly insightful and helpful.
And so meanwhile, until we do that, having positive outcomes on multiple measures is important.
Yes, absolutely.
And one thing I know from the quantitative research we did was that there were a number of people so the methodology was you had to be confirmed by a clinician as having a certain level of disease. And there were a number of people whose clinicians referred them to us as cognitively normal, who told us, that's not how I feel. And yet that's what the clinician reported them to us as. So what does that say to you as someone who's been trying to measure these things for years?
It's one of my favorite findings, not because I think it's optimistic, but because I think it's extremely important. We did indeed find that these patients who were technically asymptomatic still were reporting important changes that they were experiencing. So it's telling us that we don't have enough detail in our assessments or the questions our physicians are asking. And that's where my comment about this foundation can be equally important to improving our clinical trial metrics as it can improving the conversations and the measurements used in the clinic by physicians. So I think it's telling us that we're still not very good at at understanding the nuance of initial changes. And as we are getting treatments that are going to be valuable earlier and earlier in therapy, it's going to become even more important that we can not only be aware of them, but quantitatively assess them so we can see and understand when patients are declining less, for instance. So it's, as I said, one of my favorite findings because of how it clarifies all the work we have to do.
Thanks.
It is. I would agree with that completely, Anne. And I think that we've gotten very good at developing highly precise and sensitive neurocognitive assessments, but somewhere for our field to move would be being able to detect some of this more subtle functional decline and what patients are describing to us that they feel and experience, being able to measure that.
Absolutely.
Thank you. All right, now to bring in some other really smart people to this conversation. We'll be joined by Dr. Sharon Cohen, who is the medical director of the Toronto Memory Program, where she sees people with Alzheimer's. She's a behavioral neurologist and a clinical trialist, been a site PI for over 160 trials. Dr. Scott Andrews, Global Director of Evidence and Outcomes at Takeda, worked in health economics and outcome research for many years and is a pharmacist by training. Dr. Lee Callahan, who wears two hats in this conversation. Lee is a professor at UNC School of Medicine, focusing on rheumatology, but she's also an advocate for Alzheimer's caregivers, as she was one for a number of years, taking care of her husband, John. And finally, last but absolutely not least, and actually essential to this conversation, Doreen Monks, who is a retired neuroscience nurse practitioner, but she's not here because she's a neuroscience nurse practitioner. Doreen's here because of why she had to retire, which is that she's living with early onset Alzheimer's disease. So thank you all for joining us in this conversation. And let's just jump right in. So Sharon, you see patients a lot, and you heard the report from Anne and Carla. How does that kind of jibe with what patients tell you?
Thank you, Russ. It's a pleasure being with everybody. I hope you can hear me well. Carla and Anne, thank you so much for the work that you're doing. The patients are absolutely front and center, and without their voice, I don't know what we think we're doing. We need to be doing good for them, as with every other therapeutic area. The reason why, or one reason why it's so complicated with Alzheimer's disease is people don't generally understand cognition and the complexity and also the great variability person to person. My linguistic skills are different than somebody else's. We're both normal. My navigational skills or my mathematical skills are different from somebody else's. There's so much variability. And then there's difference in what we value, in our priorities. For me, if I, have to be driven somewhere, okay. That's not okay for somebody who loves taking those road trips and has always found their way around. So we prioritize things differently. When it comes to physical illness, we can all have a sense of not being able to walk. Gee, that's a drag, walking is important. When it comes to memory, thinking, calculation, praxis, people just don't get it. And if we don't listen to patients, we will continue not to get it. So we have a lot of good scales, convergence of evidence, as Jeff and others have pointed out, and Carla and Anne have agreed, tell us a lot of information, map more to, more of these 42 items that you've surveyed as important. We're never going to capture the full breadth of what's important in human behavior. And I always think of my dear late parents who both died of Alzheimer's disease. My mom was a linguist and a poet, and not finding words mattered more to her than most. My dad was a mathematician and a pianist. He just wanted to keep playing the piano and learning new Chopin pieces. What scale is going to measure that? We're not going to be able to create these big scales. So we have to listen to people. And the beauty of being a clinician is you have a conversation with your patient. How's it going? What's new with you? How's the piano playing going? Whatever it is that's relevant to that patient. In clinical trials, we have set scales and we make the best. And we need to have a number of them, and we need to include quality of life items, neuropsychiatric symptom scales, and hopefully in the future, some of the IADL scales that are so important because they do capture independence, which matters to people, hopefully they will not just be care partner reported, but patients at early stages of disease have a lot to say about their IADL, and they may notice decline that their care partner hasn't yet noticed. So thank you, forgive me for rambling, but thank you for asking me this question.
And Sharon, just for the few folks on this webinar who might not know what an IADL is.
Yes, so IADL is a short form for Instrumental Activities of Daily Living. Activities of daily living is a broad category of being able to do things, whether it's banking, shopping, dressing oneself, feeding oneself. We subdivide into two broad categories: instrumental activities, which are higher level items that require more interaction with the environment, let's say, being able to prepare a meal, to grocery shop, to travel. And then basic, or BADL, basic activities of daily living, which refer to personal self-maintenance skills like dressing oneself, feeding oneself, toileting and grooming. And with a disease like Alzheimer's disease, at the early stages, it is the instrumental activities, the IADL, that are at risk first and are lost first, and then later the more basic activities. But we don't lose all activities in one category all at once. It might be, I can't do my job anymore. Depending on my job, I can still travel, I can still bank, perhaps I can still drive, or I can't drive anymore, but I can still do many other things. So there's a lot of variability again, and we need to think broadly about this disease, and not only the variability in what declines in what sequence, but what the priorities are for patients.
Thanks. So Lee, you in your professional life have been involved in developing patient-reported outcomes in rheumatology. And in your personal life, you've been involved in watching patients take those outcomes and being probably a reporter on caregiver-reported outcomes. As you put those two parts of your world together, what do you want people to know about this, especially in terms of what Anne and Carla just reported?
I'm glad you talked about my two worlds, because I can't really distinguish them. And that was the interesting thing in jumping into the Alzheimer's world. I, for 30 years, have valued the patient input and the patient reported outcomes. And, in rheumatic diseases, as in Alzheimer's, I don't know that, a lot of the things that Sharon was talking about, we're interested in instrumental activities of daily living as well as basic activities of daily living. And I saw with John that there were things he could do on the questionnaires that were being administered, particularly early in the disease. And I am so thankful that a lot of the first panel talked about early disease and the slope of the disease and flattening the slope so that you're not on such a steep trajectory to get worse. And that would have meant the world to me and the world to John, to keep him slow, to slow the trajectory. We never had any idea coming from chronic disease that we cure it, but we wanted to manage it and keep things manageable. And I value what we're doing in AD PACE because it is trying to get at the nuances that Sharon mentioned and the subtle differences, and particularly early in disease. And obviously we're not there yet, but we're thinking about it. And the more qualitative work we do, and I guess the more sophisticated the whole science of PROs becomes, maybe we will be able to detect those subtle differences early in the disease. And I want to help do whatever I can in that arena.
Thank you, Lee. Now, Doreen, you care about patient-reported outcomes, PROs, but you also care about some pretty fundamental things in this disease. What matters most to you?
I'm 8 years out from diagnosis, and I was, I guess, blessed in a way. I was diagnosed very early, much earlier than most people would have been, because I was lucky enough to have a neurologist across the hall from me while I was working. to me, the most important thing is for me to be the person I am today, tomorrow. That I can, the things that I can do now and be independent, I will be able to do tomorrow and the next day and the day after that. You know, to look at the research and, you know, somebody could scoff and say, oh, 27%. 27% to me means I may get 3, 4, 5 years longer to be the person I am today. You know, when I looked at the data and saw the you know, the significant change in ADLs, that was almost made me weep, you know, because it is, you know, I have hypertension and I have a mild atherosclerotic disease, coronary artery disease. Those clinical outcomes of the treatment are basically clinician measured, you know, keep your blood pressure at a certain level, you know, slowing down or perhaps reversing the atherosclerotic changes. It's not the same in Alzheimer's disease. I have to be the person who decides if what I'm doing or what we're doing is working. You could measure something on your own and say, well, this particular aspect is you know, doing well. But to me, it's, you know, I think it's important that, you know, when you were doing the study that the people came in who were theoretically cognitively normal really weren't, you know, and I'm at that level. I'm not the person I was 8 years ago. I know that, you know, and I think that, you know, but I meet people and they say, well, how could you possibly have Alzheimer's disease? You know, it's, well, I do. I have pictures to prove it, you know, but, you know, the thing is that it doesn't matter what you think in some respect. It matters what I think. And I'm very happy with where I am now. And my goal is to stay here. And to me, the cure is very much like, because it is a chronic disease. So it's very much like hypertension and diabetes and heart disease. The cure lies in the fact that you are managing the disease and you are keeping yourself at your highest functional level. And I think, you know, that's my goal. You know, my goal is, you know, I don't have a caregiver. I'm a single person. I live alone. So it's imperative to me that I maintain my independence as long as humanly possible.
Thank you. So Scott, you wear a couple of hats in this conversation too, because you've been involved in the 80 PACE What Matters Most research, but you're also the lead author on a paper that is coming up a lot these days. I would say maybe misused in some cases, or maybe used by people who didn't get to the limitations section and read the whole paper. But tell us what you were trying to do in that paper, and what would you say to people who say that what your paper stands for is that the minimal clinically important difference between groups in Alzheimer's disease at the earliest stages is obviously 1 to 2 points on the CDR sum of boxes?
Yep, really important question, Russ. I can say our aim at the time, I think in many ways, is very consistent with the discussion we're having today. And that's how can we define clinically meaningful change at the individual patient level. And I'll continue to underscore that because I think we all recognize how fundamental that is when we're talking about what matters most. What patient-focused drug development is really about is getting at that individual patient voice. You know, the challenge that we faced years ago is that really the challenge that we face now is that we really lack consensus on what constitutes a clinically meaningful within patient change score on these clinical outcome assessments that we employ in clinical trials. So to address that at the time, we did turn to the regulatory guidance, and you'll see that it recognizes that I think it describes it as a useful way, certainly not the only way of supplementing our understanding of a clinically meaningful benefit is through the use of a responder or progressor analysis. So what does that mean? Let me bring that to a relevant way of maybe coming down to the patient level. That would be to say and ask of our clinical trial, does this investigational treatment slow the time to reaching a meaningful deterioration or a meaningful threshold of progression for more patients? And we thought that that was such an important question to investigate at the time because we were just starting to run the trials in the earliest symptomatic stages of Alzheimer's disease at that time. So MCI due to AD, prodromal AD. And what we recognize is we really lacked those, what I would call interim clinical milestones that have really high face validity for all of our stakeholders. So remember, a lot of our payers, our policymakers, even some of our clinicians and patients and other advocates out there, we're still entrenched in a world where death, full-time disability, nursing home placement, these were the relevant clinical outcomes that they're thinking about for future treatments. And we recognize we needed a way to talk about delaying the progression to something that was still really relevant, that reflected maybe more of those subtle changes at the time that these patients are in the continuum of their disease. So as you say, we used accepted techniques to define this threshold of within patient change. It varied by the stage of disease that the patient was in, but you're right, on average, it was that 1 point on CDR sum of boxes is what we described as a really good starting point for the field to use at that individual patient context level. Now, let me come back to maybe the most important part of your question is how have we seen it applied? And this is where we've actually seen, unfortunately, there's been a description that 1 point change on a CDR sum of box, instead of using it in a way that allows you to look at that individual within patient change, that's going to be important for determining clinical meaningfulness. We've seen it mandated as this is what's necessary to be clinically meaningful between groups. So that's to say, the magnitude of difference between the treatment group and the placebo group should be this 1 point change on CDR sum of boxes. And we know that's entirely inconsistent with the guidance. That would be an inappropriate way of applying that analysis. And unfortunately, it sets up some very unrealistic expectations for these emerging therapies. So this is a great chance to clarify that. And again, I think that the path forward is to continue to use the spirit of what we're talking about, what matters most to patients, to really identify these within patient changes that we can then use to define clinical meaningfulness. Because I think as we continue to see the patient-focused drug development adopted in all of our research, that's really what's clear. That is what should be used to define clinical meaningfulness and not between group differences. So an important chance to clarify how that's been used here recently.
So Scott, just to put a fine point on the within patient versus sort of the average between groups, asking someone who last took stats a really long time ago, what does comparing averages between groups sort of wash out? I think that's what happens, right? It sort of washes out within patient, or could wash out within patient differences.
Exactly. It says nothing about the clinical importance of that within individual patient change. So, again, these were all things that we were anticipating at the time that we conducted that research. I think what Dr. Irizarry showed in some of their analysis around delaying the progression to CDR stages, we were unsure if there would be that amount of progression during an 18-month or 24-month trial at the time. But that's a very relevant way of doing it. Very similar. There are different attempts. We tried to use sort of a unique approach using anchored to clinicians' impression of important change. We used a unique data set that may not be consistent with the patients that are currently enrolled in clinical trials or being treated in normal clinical practice. But that's exactly what it is. If you use the between group difference, it completely misses the point of understanding what's happening within patient change or the individual level.
Anybody want to add to that or ask Scott any questions before we move on? Sharon.
Sorry, maybe I could just say, Scott, I'm very interested in and encouraged by your comments, and I think the purpose of your paper what you're trying to get at the time makes great sense, and your understanding that people have applied some of the results much too rigidly also encourages me that you understand very well that we're not done with this exercise, and to say that one must have a change score of 1 or greater on the CDR sum of boxes for a drug to be meaningful just makes no sense. And yet we find ourselves in this very serious battle to prove to many scientists, and I know, being in Toronto, at the University of Toronto, there's a very fixed belief that we must meet that, CDR sum of boxes threshold. So thank you for your comments. They're enlightening, and I completely agree with them.
Russ, since you noted some of the recent publications, the Alzheimer's Association just had a publication yesterday. It commented on that, and I think many of my colleagues in the field have also done great work. Some of you on the line in collaboration with them. Thank you for your continued efforts for clarifying in a sort of further approach. And I'm hoping that we're reaching a point where we'll be able to rebut some of those inappropriate applications that we're seeing in some of the guidance and other important documents that this is being adopted in, unfortunately.
Sure.
Thanks, Scott.
Sorry, Scott. Sorry, Russ, if I could just make one more comment. When we look at a change score in the CDR sum of boxes, for example, it's very time-based. If you have an intervention like lecanemab, which shows increasing effect over time, and we look at the slide, that Michael Irizarry showed us with the slope analysis of 32% slowing per year, then by 18 months, we have a CDR sum of boxes change score of 0.45, or I think it was 0.46 by slope analysis. But if you extend that out to 2 years or 25 months, now that's a change score of 0.68. So it's very time dependent, and we shouldn't get too hung up on a snapshot just at one endpoint of a trial based on the trial duration.
Yeah, it's the limitation of an 18-month trial, right? I mean, that's a big issue in our field, is that because it's such a heterogeneous disease, progressors and slow progressors, there's got to be a limit to the number of years you put into a trial. But it does mean that you cut off things and then have to make some assumptions about what happens afterwards. Anne, it looked like you were going to add on to that.
Yeah, I was. Thanks, Russ. I think that, looking at that saved time or that additional time to delay is an incredibly powerful way of looking at this. And we're finding thus far, we need to do more research, but we're finding that seems, that delay seems to be pretty constant. Because when you take these points of time and look at them vertically, essentially, you're so dependent on what the placebo change was, and so, and it's not, and it doesn't have any inherent meaning. So again, going to, as Doreen was saying, it's tomorrow that matters, not the difference today. It's the difference to tomorrow that really matters to her. And so looking at these time-based analyses are incredibly valuable, and I think get much more to what our patients value.
Yeah,
I think that was what I was so encouraged by. And when you see the data as it came out, from the 3-month period to the 6-month period to the 18-month period, it's like, wow, this is not just a fly in the wind here. This is something that's showing, that potentially if you keep going, the outcome could even be better. So, again, we're at a precipice of something really important, and, for those of us who are living with the disease, instead of a black hole of what tomorrow is going to be, there's a light, and that's, to me, the only thing I have right now is hope, and hope that tomorrow will be like today, and anything that can be done to make that be, to me, it's worth whatever risk because this is a fatal disease. I mean, yeah, it takes a while to get there, but the fact is you don't survive this disease. So if there's a risk involved, I'm personally, much like, I have rheumatoid arthritis, and I've been on a monoclonal antibody for that. We made the decision on what drug to take based on the risk versus the benefit, and I want the opportunity to do that, with this disease as well. I trust my neurologist, to help me make the right decision.
I think John and I would have made the decision like you, Doreen. I mean, it's looking at those data. When you said you got teary, I got a little teary too, thinking we could have slowed things, and the risk. I used to say this in talks about rheumatoid arthritis. The side effects of the disease are worse than the side effects of the medicine. You got to look at the risk.
Exactly. And that's, you're right. I mean, that to me, it was, I'll live with the risk of, infection and the risk of, I'll monitor my white count till the cows come home, et cetera. But you're right. The benefit of getting it is worth the monthly or 2-month blood draws and the worrying about this and worrying about that, because I get a benefit from it. And I think with lecanemab and the drugs to come, I just want that chance. It may not work. That's okay. But, having hope is the key. And if you have nothing, then there's not much to be hopeful about, so I don't expect this to be the beginning, the end all of everything. And I think hopefully it's just the beginning, but I think, when you look at each individual person, this disease does not follow the course of other chronic diseases. You can't make the worst thing you can do is make generalities about this disease because it's so individually based.
Thank you. So we've heard that, what we're currently measuring isn't maybe necessarily getting it, although Michael did have in his presentation the sort of time to event analysis, which really speaks to what Lee and Doreen were just talking about. The primary endpoint was this thing called the CDR sum of boxes, which we heard from Dr. Parker is not in common use in clinical settings. And Sharon, you live in both worlds. You live as a clinician who sees patients, and you live as a trialist who uses the CDR sum of boxes to sort of rate things. And we talked about it being an 18-point scale, but obviously you don't use all 18 points early in the disease. But we didn't get much beyond that. Can you help us decode, for people who aren't familiar, even the neurologists in the audience who don't use this scale, can you help us decode what those numbers are a little bit? So if I'm generally doing okay, but I've got some memory concerns, I come in and I talk to you and I tell you I got a little bit of a problem with remembering people's names. What is that likely to show up on your initial CDR sum of the boxes?
Okay, I'm happy to try and clarify this because it is a mystery tool for those who are not actually using the CDR, who are not CDR raters, or who have not taken the time to look at this scale. It's complicated. So it is a scale that is often preferred by regulators, the FDA, for phase 3 early AD interventional trials. It is a scale that gives us a global score, which is a rating of severity. Someone is normal, that's a 0, has mild cognitive impairment or slight mild impairment, that's a 0.5, or a 1, 2, 3, which is mild, moderate, severe dementia. That's the global CDR. So those are broad scales. But the CDR also has the ability to give us much more detail by looking at 6 different domains, and Michael listed them: memory, orientation, judgment and problem solving, community affairs, home and hobbies, personal care, all very important with face validity for all of us, not just people with Alzheimer's disease. All of these categories are important. And within each of these 6 domains, we can get a subscale score, and those scores are generally 0 to 3. You add them up and you get this 18-point scale. But people with early Alzheimer's disease, and that is MCI or mild dementia due to Alzheimer's disease, tend to live in that range of 0.5 to 6 on an 18-point scale. So we're already dealing with a compressed front end of the scale, and they change slowly over time. But if we look at each of the 6 domains and we think about what does it mean to go from a 0.5 to a 1 in any of those domains, we're talking about going from slight difficulty, not particularly interfering with day-to-day activities, it's there, but it's slight, to moderate difficulty at the level of a 1 rating that is now interfering. with activity. Okay, so that's a big jump. That 0.5 change in any of the domains can represent a significant notable change for an individual, going from slight difficulty, whether it's word finding, communication, whether it's to do with home and hobbies. If you go to a 1 with home and hobbies, you are now abandoning some of the more complex activities. So maybe if you're a bridge player, you can't play bridge anymore, or you can't go on those birding, hikes that you used to do. So notable changes, and the same with any of the domains. So it is not trivial to increase by 0.5 at the early stage of disease. I hope that helps clarify.
Yeah, it does. So I'm thinking about my mother-in-law living with the disease. One of the first big challenges for her was when she couldn't go to the grocery store anymore, or if she had to have someone come with her. What would that have looked like on that community affairs subscale?
So I might need to ask a few more questions about, how much difficulty she's having, and with other activities as well, because the 6 domains don't depend strictly on one activity. We sample a number of activities to come up with a clinician-derived impression. So as much as we're getting input from a care partner and patient, the clinician is ultimately making the decision as to the scoring there. And I think that's important to remember. This is not really patient-reported outcomes. This is a clinician scale. And so she might be a 1 in that domain of, managing community affairs. She might be a 2, depending how disabled and whether other activities were difficult for her. If she could still go to the grocery store, but had a little bit of difficulty remembering what she needed, but she was still doing it independently, she might be a 0.5. So again, it's very nuanced, and there's a lot of room for clinician interpretation. And that's why there's training within trials for clinicians to get this right, or at least be uniform and have test, retest, and inter-rater acceptable, very limited variability. And it's never going to be a tool that is used in clinical practice. It's too complicated, it takes too long, and it requires this training and retraining to get it right.
Thanks.
So, Russ,
Can I, Carla's probably going to say the exact same thing I am. Go ahead, Carla.
I was just going to say that this is where the what matters most really comes into play, and then being able to capture some of those nuanced differences. So being able to dig into the individual or patient report allows us to measure these things, I think, with a different level of precision than the clinician reported outcomes allow. Was that close?
And just to give a little preview of our paper that's coming out, our 2 papers that are coming out next week or within the next 2 weeks. For instance, the CDR, as sum of boxes, is one of the top 5 measures in terms of overlap with what matters most to patients, but it still only hits 12 of the 42 concepts. Just to put everything in perspective here.
Thanks. So, Scott, I want to just go to something a little more abstract before we close out, which is that we didn't talk much about the conceptual model that Carla shared. And you've been involved with the 80 PACE initiative, but you're also involved in trying to develop new drugs. How does the conceptual model sort of guide and aid the field from your perspective?
Yeah, well, I think, first of all, Carla and Ann did, I think, a beautiful job of representing where it could go and where it has promise and utility. So certainly the measurement field views a tool like this as sort of the foundational framework for scale construction, right? So if there's additional interest in building novel scales that maybe address some of the limitations of current scales, then it absolutely is sort of a blueprint to help measurement scientists to do that. I think the challenge for all of us and for the field is to think about now. We've got a lot of promising trials that have used some of these scales that have noted limitations, and I don't think anybody listening to Carla and Ann are surprised to hear that. We've known that these were often tools that were built without maybe the depth of qualitative input or certainly targeting patients that are at a different continuum or spectrum of the disease that we're now studying in our trials. So there needs to be effort to, how do we use this conceptual model to further validate maybe the scales that we have used, to just be aware where there are those gaps. I do think that there's maybe promise in thinking about how there can be some novel mapping, rescoring, scaling of existing scales to maybe optimize or just highlight the features that are now part of this conceptual model. So I think that's next steps that the field will want to think about. And then importantly, beyond just new scales for clinical trials, I think it was noted that there's going to be really important efforts for patients that are receiving these new therapies in the course of routine care. So ALSNet, other observational or type of studies, I think it's going to be important to think about instrumentation there. So if it's not a novel scale, which scales maybe capture more of these relevant signs, symptoms, and impacts that are represented in this conceptual model. And I think the other thing that, as I was just looking at this and hearing people talk about it today is, especially for some of these signs, symptoms, impacts that are maybe more novel and that we've heard are important to the patient, then it's incumbent upon us to start telling the story of what that unmet need looks like for these patients, what that means to the patient, to the healthcare system, to society, because certainly part of this greater discussion about value is building that understanding of how these concepts are related to that overall burden, and hopefully how our emerging treatments will address some of that burden that's represented here. So I think a lot of fascinating ways that this can continue to grow.
Thanks, Scott. So as we come close to the top of the hour and the end of our time together, which is really flying by, I want to ask Lee, so while we all work to figure out this next generation of what tools are perfect to really capture this, we've got to apply what we've got today in this disease. What's important to you as a now former caregiver? What's important to you that we get right while we move forward on these two lanes of developing the ideal, but also living with what we've got? What do we need to get right? Probably
more education of people who are in the field, the clinicians and the providers, who to let people know that some of the things that were highlighted today need to be considered, whether it's, considering more of the items in the conceptual model, bringing the patient in and understanding very deeply what Doreen said. What matters is, how am I going to be like this tomorrow? And how long am I going to remain independent and functional? And now that I'm single and don't have a caregiver, I think about what you said very deeply, Doreen, that if I'm diagnosed early, I want to know how long I can keep independent and functional.
And Doreen, last word from you.
You
don't have time to wait for us to get this perfect. We have to get it right now. What's
basically, yes. I just think that you just have to, I don't want the scale. I don't want to have to adapt to somebody's scale. I want their scale to adapt to me. I and as me, not three other me's, because you can have this three other people in the same level of disease and be in the very significantly different effects. And you're right, it is about today and tomorrow. You're dealt, when you get this disease, you're dealt with a bit of a finite period of time, not so much from the diagnosis to death, because we're all going to die, but there's that point of, I have Alzheimer's disease now, but how long will I be me before I become somebody else and I'm no longer the person I am? And we don't know that. So I have to take each day thinking, well, today's a good day and I'm doing what I want to do, and I'm doing it independently, and I'm doing it safely. It took me, I'm on my third neurologist. It took 3 tries to get the right one. who actually understood the disease, and which is, keynote to trying to, but, and who works with me on an individual basis and asks me what's going on, not telling me what's going on, and I think that's key, that we focus on the individual, because the presentation of the disease is so unique to each individual person who's affected by it.
Thanks, Dory.
And make sure and work hard, because I'm running out of time. So so let's get the lecanemab approved and everybody happy, and I'm lining up.
Thank you, Doreen. Thank you all to this panel, to our first panelists. This has been a great discussion, everything I think we hoped it would be. If you are registered, you will get a link to the YouTube video with all of this content. Probably going to take us a day to bring it down, put it back up, and do whatever we have to do mechanically. But within the next 24 hours, you should have access to a YouTube video. Thank you to the audience who joined. I think we had almost 300 people joining us live. Thanks again to the panelists. Thanks for your time. Have a great day, everybody.